Hey everyone, Dr. David Clark. Today I'm going to be walking you through another real patient case study from my office. Today we're looking at a 46-year-old woman with a previous diagnosis of Meniere's disease, still having vertigo, nausea, tinnitus, and hearing loss. So, 3 months before seeing me, she had 9 attacks in 1 month. Now, if you've ever had a Meniere's attack, you know how terrible it is. The vertigo, the nausea, it's debilitating. She had 9 of those in 1 month before seeing me. In the previous immediate 30 days before seeing me, she had 5 attacks of this vertigo and tinnitus and had repeated vomiting. So we know her Meniere's is not stable. So if you're suffering with Meniere's and you're still having symptoms, I think you're going to find today's case very helpful. So let's get into it. She also describes having visual vertigo at times when watching TV or the phone or the computer. Now, what she means to say is that the movement of visual things on her visual scene can trigger these feelings of instability and disequilibrium and dizziness. Doesn't always trigger frank, rotation, but it does make her feel really terrible. She has motion issues. Basically what she means is when she moves, sometimes she feels bad. And what she's telling you is that the vestibular ocular reflex, which is a kind of a technical thing I don't know if we'll get into, that's broken. And these are common things you find with people that have Meniere's, especially the more severe it is and the longer they have it, they become less and less able to tolerate visual movement, and they become less able to tolerate their own movement in space. Of course, she has nausea. She has the tinnitus and hearing loss. That should be another bullet that says sensitivity to sound. And she has pressure in her right ear, all kind of classic Meniere sorts of symptoms. So let's check out the history. In 2003, basically 20 years ago, she was diagnosed with Hashimoto's. Now, Hashimoto's is an autoimmune thyroid condition, and I'll just tell you right now that if I didn't know anything else about her, and all I knew is that she had Meniere's disease, my first suspicion is that it's going to be an immune system problem. Now, when I look in her history, I find out 20 years ago, yeah, she was diagnosed with an immune system problem because Hashimoto's is an autoimmune thyroid condition. And I don't know if you know this, but I treat a lot of Hashimoto's patients, mainly because it's the most common organ-specific autoimmune condition we have. It's the most common cause of hypothyroidism. And there's a big correlation, as we'll talk, between the immune system and Meniere's disease. So the endocrinologist told her, this is a quote from her intake, she said, the endocrinologist basically sent me home with a brochure, and that was that. And unfortunately, this video is not about Hashimoto's, but I have a million videos on Hashimoto's. That's pretty much what most Hashimoto's patients get told is, you have this autoimmune thyroid problem, I'm still going to give you Synthroid. As soon as your TSH is normal, then you're fixed. Which, as you can imagine, is not really what happens for the vast majority of people. Sure, some people kind of get lucky and they feel great when they take their thyroid medication, but as evidence of the people that I see, there's a lot of people that have Hashimoto's. They take the medication the way they're supposed to, their labs look good, but they don't feel good. So that's a topic for many other videos I have. I just wanted to kind of give you the context for that. All right, so in March and April 2009, she began having bilateral tinnitus. She took some steroids, they didn't help, but eventually the tinnitus resolved, which is good. The next year, about a year later, April to September 2010, she had her first vertigo attack. She went to the ER, was given meclizine, which is basically a vestibular sedative. She then had vertigo attacks on and off for 5 months. Those attacks could last for hours. And speaking as someone that's had a Meniere's attack, it is terrible. The quality of life for people that have these attacks is really, really bad. It's debilitating. Now, at the time that she was having these attacks, the ENT said it couldn't be Meniere's, which I don't understand how they came to that conclusion, but that to me brings up a good point about how some doctors just, unless they can give it a really book name or you check all the boxes, they don't want to do anything. I mean, even for me, Meniere's is just a label. It's just kind of describing what's happening. It's not going to really tell you what to do about it. Now, granted, how I'm approaching this is different than the way the vast majority of ENTs and other people do. Basically, they're going to tell you to do a low sodium diet, maybe give you a diuretic, occasionally give you steroids, and that's it. But for many, 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 many Meniere's patients, that is not enough. They're still unstable. And I kind of laugh at the fact that this guy said, it can't be Meniere's. Why? Why can't it be Meniere's? Can it be the process that leads up to getting the full diagnosis of Meniere's? It's just pretty sad. But she also noted that she also felt worse after eating sweets, but that might have been the gluten as well as the sugar. All right, in 2011, she went on a gluten-free diet, which she should have been doing anyway because of the Hashimoto's. And she has been gluten-free ever since for 12 years, kind of like me. I have celiac disease and I haven't had a gluten in 15 years, almost 16 years. And the gluten-free diet really did seem to help her symptoms. Okay, great. That is a good sign. But that is usually not going to be the single thing that turns the Meniere's all the way around. About a year later, she was diagnosed with Hashimoto's again. Basically, I'm assuming that someone did the antibody test, the thyroid peroxidase with thyroglobulin, and they said, hey, your antibodies are high, but your TSH, your T4 are not, and that's why they're saying they were not bad. So she had euthyroid Hashimoto's, and there's kind of a spectrum where euthyroid means you have the antibodies, but the TSH and T4 are fine, which means you're still making enough hormones, so you just have the antibodies. But here's the thing. Just having the antibodies is enough to cause problems because it's telling you the immune system is out of whack, that your immune system is attacking you. Unfortunately, though, the people she saw 10 years ago had nothing to offer her to be proactive, not reactive, right? So about a year later, she began feeling bad again for quite a while. And then she changed her diet, and the brief waves of dizziness she'd been experiencing in a couple months prior to that went away, fatigue resolved. I'm not going to bother you with the diet because how she changed her diet is not necessarily what you would want to do or what we want to do with somebody else. But she's treating herself here, right? That's the thing is she's not getting any guidance. She's not working with anyone that has any experience or any real knowledge, unfortunately. And so she is self-treating, and she's kind of getting a little bit lucky. 3 years later, in July 2017, she began feeling pressure in the right ear, the tinnitus and the hearing loss, which again eventually resolved. So it's kind of like, Meniere's will do this thing where it kind of waxes and wanes, right? It gets worse and then it'll kind of resolve. Sometimes it'll resolve on its own. Sometimes people will get a steroid shot or an intratympanic steroid shot, but you know that it's not stable, right? Because it keeps coming back. And 2 years later, she had a vertigo attack. She had an aura of pressure and hissing, which means that pressure was increasing inside her ear. And that occurred the day after a concert. And so, not to get too much into how you can have sound trauma, but essentially loud sounds are traumatic and they can create a little oxidative stress in the ear, which is inflammatory, which can trigger an attack like it did with her. She had 2 more attacks in the same week, and then the symptoms seemed to recede. And then a couple months later, she had tinnitus in the right ear, began again, and has not gone away. Now, in December 2022 through July 2023, she had 3 attacks in December, 3 in January, 2 in February. That's a lot. That's a really, really unstable Meniere's. Then she had 5 weeks without an attack after stopping all of her supplements because she's self-treating. She's trying to do her best. She could have been taking something that wasn't good for her. She's not sure if there was a correlation. There very well could have been, I can tell you. But anyway, so she had a bunch of attacks. All right, then March 10th of 2023, she had a sinus infection. And then a few weeks later, she had vertigo. So again, the pressure increase from the sinus infection could do it. It could have been the inflammatory response to the infection. In April, she had 9 attacks, 9. In May, she had 6 attacks and has clear hearing loss in both ears, and the right ear is worse than the left. And then on May 12th specifically, she began taking beta-histine, which is something that some ENTs will prescribe, some won't. 2.5 weeks later, she had another attack, so she stopped taking it. And then on May 18th, she stopped driving due to the frequency of the attacks. Now, she's married, she's got kids, and not being able to drive really puts a cramp in being able to, be a wife and a mother and be able to work and be able to contribute to the family and feel like you're part of the family. And that's something I've seen in many cases. I have another case that I posted before about a guy who stopped driving and wouldn't drive his grandkids anywhere because he'd had a vertigo attack while driving that really traumatized him. All right. June 11th, she had a vertigo attack while watching TV. She began taking HCTZ, which is a diuretic, as well as potassium chloride, which is an attempt to replace some of the potassium she loses with a diuretic. She felt a lot better and went on vacation for about 10 days. And again, that's great. Then 2 days after coming back, she had an attack on July 4th. She thinks that might have been related to sodium intake. It can be. Sodium is Sodium, of course, attracts water, but it also is inflammatory above a certain threshold. So it could have been either one of those things. In fact, I have another video that I'll be posting in my Meniere's triggers all about sodium. It might have been related to the sodium intake, and it was really bad, and she had vomiting many times over several hours. She had 5 more attacks between July 4th and July 17th. And on July 18th, she started a 5-day course of prednisone, which is a steroid. And she has felt progressively better since then, but is still having pressure in the right ear. And that's often how steroids are used. They're kind of used as sort of an attempt to rescue, but you just can't take steroids 5 or 6 times a year because they're terrible for you otherwise. She also told me that she had a diagnosis of Reynaud syndrome, which doesn't necessarily have anything to do with the Meniere's directly, but it is essentially an immune system problem as well. Okay, so family history, what can that tell us? So we're always looking at the family history because if we didn't already know she had an autoimmune problem or an immune system problem, having a sibling with a thyroid condition, odds are it's Hashimoto's, whether she's ever been tested or not. She has a mother with Hashimoto's, so the odds are that this lady very likely has Hashimoto's. She has a father with thyroid disease, which could be Hashimoto's. So like on both sides of the family tree, she's got thyroid problems. So she's currently taking, at the time that I saw her, she was taking vitamin D, vitamin K, probiotics, selenium, beta-histine, HCTZ, potassium chloride, vitamin C, a multivitamin, magnesium, milk thistle, and those are all her attempt to self-treat. Right? Now, there's nothing in there that I go, ooh, probably shouldn't be taking that. But there's also not necessarily anything in there where I'm thinking, we're really probably getting to the root of the problem. You know, it's just that she doesn't know. She doesn't have the training. She has no idea what she's supposed to be doing. She's, on Google and reading things, but what she shouldn't have to do, right? She should not have to do that. There should be someone she can work with that understands the physiology of Meniere's, has experience with it, that can help her rather than her trying to do it herself. So diet-wise, she already was avoiding gluten, dairy, and corn when she saw me, which is pretty good because 3 of those really should be avoided in someone that has thyroid peroxidase antibodies. So what do we know at this point? So right, I'm looking at her case, I'm working her up. Well, I know she has Meniere's. It's happening in both ears. We know she has euthyroid Hashimoto's, or at least the last time she was checked, she had euthyroid Hashimoto's. Odds are that her Meniere's is immune-mediated. It's probably an inflammatory phenotype. Now, I say probably because I don't know yet. I'm going to do a lymphocyte map when I can do one to find that out. Now, here's the thing, though. She's had steroids really recently, so I can't do my lymphocyte map. Now, the lymphocyte map is a way to get her immunophenotype. It's a way to look at her immune system and find out what is your immune system doing and what is it normal? Is it abnormal? The problem is those steroids are going to make that MAP test, that immune system fingerprint test, look falsely good. So I can't do it right now. So I'm going to have to do the best I can without it, which, I practiced for, 20 years before we had that test. And so it is possible to be done. And again, I can't do that multiple tissue antibody testing I've talked about before because of the steroid exposure. I can't do the lymphocyte map because of the recent steroid use. But what can I do? Well, I can do regular blood work, and let's see what that showed us. So kind of some pre-treatment labs, what did we find? Well, her TSH, free T4, the antibodies, and the ferritin. So let's just look at these. So you'll see that the TSH, and her vitamin D, you'll see that her TSH is high. Now, it's not crazy high, it's a little bit high, but the fact that the TSH is high, and these antibodies are high, but the T4, the free T4 is normal, that's called subclinical Hashimoto's hypothyroidism. She's not overtly hypothyroid because there's a spectrum. First it goes euthyroid where you've got the antibodies only, subclinical where the antibodies and the TSH is abnormal, and then overt where the antibodies are there, the TSH is high and the free T4 is low. So she is now subclinical. She probably wouldn't get treated for this by, I would think, 99% of endocrinologists. Now, her ferritin is a 16. That's terrible. That is a really, really bad ferritin level. Ferritin is your best test of iron. Now, that may not have anything to do specifically with the Meniere's, but she has to be feeling something from this. Typically, the goal is to have a menstruating woman's ferritin at like 50. So it's 16. And forget this reference range. I mean, just forget that. That's not good. That's a terrible, terrible ferritin value. Now, her vitamin D is a 52, which is okay. So she has subclinical Hashimoto's, and her iron is too low. Well, if we know that, and we know that she has an autoimmune problem, what do we do? Well, the treatment plan is going to be, we're going to fix the ferritin by giving her the right kind of iron at the right dosage, and there's a specific way to do that. She's going to continue that diet she's already on because that's pretty good. And I'm going to put her on an anti-inflammatory immune regulatory supplement protocol. Now, again, I'm not going to tell you exactly what that is because what I would do for you or what you should do is possibly totally different than this. So don't get mad at me for not telling you exactly what I was going to, what I did for her. And so what happens? Okay, well, 30 days, I like to do my treatment plans in 30-day chunks. So 30 days later, here's what she says. She says, well, I had a bad vertigo attack on August 22nd, 2023. That was a couple weeks after we started. And then a week later, the balance was improved, but she was having a lot of pressure in her right ear. And 3 out of the last 4 weeks, she was in bed. Well, that doesn't sound good. I got to say, it doesn't sound like we're doing very good so far. And then on the 12th of September, she's feeling a little bit better. And some balance issues are happening even while walking if she's moving her head quickly in certain angles. Okay, here's why that caught my attention, because she's telling me that her vestibular ocular reflex, which is what stabilizes your vision when you turn your head, that's not working. And that gets my interest up because if it's this bad, what may be happening is she may be having a severe kind of decalibration of some circuits, which I'll talk about in just a second. So she's still having pressure in both ears, right worse than left, occasional random buzzing in the left ear. She can tell that her hearing is definitely decreased in the right ear. She feels like she's having a pattern of about every 3 weeks an increase in symptoms. Well, that little, that up and down thing, that's the immune system for sure. But we just don't know exactly why yet, right? We have not obviously gotten ahead of it. Well, let's see what happens. So I'm telling you that I mentioned this decalibration. I'm going to show you something on the next slide. There's a thing I call the balance stability pyramid. And I think it's really important in this patient's case because Meniere's patients almost always have a metabolic problem, and she clearly has some kind of immune system thing going on, but they almost always also have circuit problems. So let me show you what I mean by that. She might need to do what we call brain-based rehabilitation while we're working on this metabolic stuff. So let me explain that. So this is what I call the balance stability pyramid. And you can see at the bottom corners of the pyramid, over here on the left, you've got the signals coming from your eyes, vision, right? And then over here, you've got signals coming from the joints and muscles in your neck, primarily your upper neck. And then over here is the signals coming from the vestibular system. Now, those things together are what give you balanced instability. Now, at the top here, though, there's this structure called the cerebellum in the back of the brain. Now, why is that there? Because the cerebellum allows there to be smooth and accurate and coordinated movement, and it integrates all of this stuff, right? It's a calibrator. And people with Meniere's, if you can imagine, this vestibular system input goes down. So something else has got to turn up to take up the slack. And that can make you very vision dominant. It can make you have neck pain. But all that stuff can only happen if your cerebellum is working correctly. And the longer and more severe and the more up and down your Meniere's is, your cerebellum can't calibrate. And so what she's probably getting with these, head movements is she's moving in an area that is not calibrated. And it can cause vertigo and nausea because there are what we call autonomic consequences. Autonomic means blood flow and blood pressure. And so without giving a big deep dive, I recognized what she was telling me. It's like, you know what? She needs brain-based rehab, meaning there's some things you can do to take this part of the brain to the gym while you're trying to metabolically take care of this. And so we started doing that. So what we're going to do is we're going to retest her ferritin in the next 30 days, continue the diet, continue the protocols we have, the anti-inflammatory, and we're going to start this brain-based rehab, and I'm skipping over a lot of the examination stuff, and we're focusing on what we found was right cerebellar function. Not surprising, right? Because the right ear is the worst ear. Well, the information from that ear that should be feeding that pyramid is sucks. It's not good. And so we're going to work on that cerebellum to see if we can help it calibrate the difference in the different corners of the pyramid. All right, so after 60 days, right? So we've introduced the brain-based rehab. We're doing some of that with her. She's still taking beta-histine and HCTZ. All right, the symptoms have been up and down. The last week's been better. There's been about 3 or 4 days that she's been out of bed and doing rather normal sorts of activities. That's nice, okay? Maybe we're making a break here. She was active Monday, Tuesday, Wednesday, feeling a little more off balance today. The last full-blown attack, though, was about 2 weeks ago, okay? So perhaps we're kind of coming out of the tunnel here. We did recheck her ferritin, which we'll see right here is a 21, and that's better than it was before. Now, something I mentioned here is the methylmalonic acid. Why is that there? Well, that's something that got left off of her initial workup, and that is the best test to look at her B12 levels. And that is not great in my book. Methylmalonic acid is inversely proportional to your B12 level. So the higher it is, the lower your B12 is. And pretty much my cutoff is around 250 or 260 that I use. So I think she probably needs to be taking the proper form of B12. And her ferritin previously was 16. It's gone up a little bit with supplementation. That's not life-changing, but it has gone up. So that's kind of nice. So she needs B12. Ferritin's better, but not great. All right, so let's see what happens. Oh, now enough time has passed since she had the steroids that I can do the lymphocyte MAP. And this is very helpful for me as her doctor because now I can see that there's a few things that don't look right and a few things that look okay. So first thing is her total white blood cell count is very much on the low end. Her total lymphocytes are really on the low end. Really, we want those to be around 2,500 at least. And then the next thing we see very clearly is that her total B cells are low, her percent B cells are low, and so the T cell B cell ratio is way off, right? So that B cell area is really catching my attention. And not to give you a big immune system lecture, but B cells are important for immune system memory. And here's why that matters. If you get exposed to a microbe, whether it's a virus or a bacteria, if your immune system's working, it will remember that you got exposed to that. And so the next time you get exposed to it, it doesn't have to work so hard and your response may not be as big. But she is probably not having that happen, right? This immune system memory may not be working well in her. And the only way I would have had any guess about that is having done this test. Now, the CD4, CD8 ratio is a little bit off. I'll skip over that just for time's sake. And then look down here, though. All of these natural killer cells are very elevated, very elevated. Natural killer cells are part of your innate immune system. They're part of your first line of defense, and really their job is to kill viruses, tumor cells. And I don't think she has any type of cancer, but those are quite elevated. And she swears that she hadn't had COVID, in months and months and months. But this looks like someone whose immune system is trying to kill something, not necessarily autoimmune. And the reason I say not necessarily autoimmune is because her Th1, Th2, Th17, all that's pretty good. And I'm giving way more details than I usually would on this. The point is this phenotype right here makes me think she may not have efficient immunological memory. And the reason she's getting flare-ups so often might be, and I keep saying might, because she's getting exposed to microbes just in her environment like everybody would. I mean, she's got kids, and she's having a response to that, and it's that response that's flaring her up. I hope that makes sense, right? Because if she was having memory, then the next time she got exposed to the microbe, she wouldn't need to work so hard. But her immune system is having to work the same degree of response at the 10th exposure as the first exposure. And that's not how it's supposed to work. So I think that's what's probably causing the flare-up of her symptoms. And of course, those NK cell numbers, the natural killer cell numbers, that could be post-infectious. It could be actively infectious, so it's probably not active infectious. But her immune system looks more deficient than inflammatory. Now that's different than what I said originally, but the only way that I know this is because I did this immune system fingerprinting test to find out. All right, maybe there's a chronic viral challenge or some kind of chronic microbial challenge, and that's not being exotic. That's just trying to problem solve. So what am I going to do with that information? Well, we're going to continue that diet she was using. We're going to continue the kind of immune regulatory protocol. But now that I know that the B cell numbers are low, we're going to add a couple things to try to improve them. Again, I'm not going to tell you what they are because I don't want you to try to self-treat like she did for years and years. And we're going to continue that brain-based rehab where we're working on that cerebellar function. All right. After 90 days, I spoke to her and she had completely discontinued the diuretic. That had been about a week at the time that I had talked to her, and she hadn't noticed any real difference, no ill effects from that. She's titrated the beta-histine down to 1 time per day, and she's planning on decreasing it to nothing. She has not had a full-blown vertigo attack in 2 months. Okay, so in 2 months, now we're vertigo attack free compared to 5 attacks, in the 30 days before I saw her. So something is working, right? Occasionally, she's getting some mild lightheadedness, some dizzy symptoms that might last for about 10 minutes. Now, there's been a dramatic decrease in the duration in those dizzy symptoms before care. I think she's doing pretty well so far. I mean, she thinks she's doing very well. I'd like to recheck the ferritin and the methylmalonic acid in about a month or so. So, what's the treatment plan after 3 months into it? Retest the ferritin and the methylmalonic acid, continue the diet, continue all the protocol I have her on, continue the rehab, and let's see what happens. So 4 months into treatment, she's had no vertigo attacks for 3 months. Okay, have an occasional momentary dizziness with certain head positions. We're still working on that, particularly when leaning over, which is probably an anterior canal problem. Now, her main complaint, though, is no longer the vertigo, the nausea, etc., because she's asymptomatic essentially with that. The problem is she's still fatigued. So we looked at her blood chemistry, which showed that the methylmalonic acid had improved tremendously, which is great. It used to be 254, now it's 137. But the ferritin, which used to be a 21, is now a 15, so that's not stable. So that's probably why she's fatigued, is she has really terrible ferritin, terrible iron. So why would that be down again? Well, there's some other stuff I didn't tell you because we were focusing on the vertigo and the dizziness, but she has really heavy menstrual periods. So, considering the lack of response to iron supplementation, I basically said, hey, you probably need to get screened for uterine fibroids. Once we find out if you've got those or not, there's some other things we can do, and I'm not going to dive off into that too much in this case. But she's going to continue everything else. All right? So what happens now? Okay, we're 5 months into it. She's now been attack-free for 5 months. We're 5 months plus into it when I followed up with her. Okay, she's off of 2 of the anti-inflammatory things I was having her use with no ill effects. She's not taking the beta-histine. She's not taking the HCTZ. She says she's doing excellent. Right? Her energy is better. She started exercising in the last 2 weeks. She started jogging and enjoying it, and no increase in symptoms. Now you can imagine, you're jogging, what happens is your head moves like this. And if her vestibular ocular reflex, and if that balance stability pyramid was still as terrible as it was, she would not be able to do that. She's starting to feel human again, right? She's starting to feel like she can drive again, which, spoiler alert, she does end up driving again. So this is really, really good. Now, the screening for uterine fibroids was negative, so there's now some things I'm going to do botanically to try to help her periods not be quite so heavy. So on the treatment plan, we're going to add some support to decrease the heavy periods. Again, not going to tell you specifically what that was. Continuing the diet, continuing the other protocol. We're reducing the brain-based rehab because she doesn't really need it as much. She's going to do more of it at home at this point. And before treatment, I'm going to summarize here. She had 5 vertigo attacks in the previous 30 days before I saw her. Now she's been vertigo attack-free for 5 months. And actually, coming up, this is going to be almost month 7, she's still vertigo-free, okay? And her chief complaints are not even related to the Meniere's anymore. It's related to something else, which I'm also going to be able to help her with. So why do I show you this? Well, because she's happy with it, the stability of it. I'm happy with it. I'm going to get happier and happier the longer it goes. And the reason I shared this case with you is that, she had to treat herself for a long time, and she just didn't know what to do. And I was able to do some of the diagnostics, but even I wasn't exactly correct, right? Because I thought, hey, it's probably an inflammatory phenotype, but really, this is another one of these Meniere's cases where it was more of an immune system deficiency that led to flare-ups, not that it was just overtly autoimmune. And again, the only way I would have known that is been able to do that lymphocyte immunophenotyping test. And, make sure you're working with someone that understands all this stuff. If you have Meniere's and it's unstable and you're still having symptoms and you're still suffering, there is hope, okay? There is hope, but you've got to get the right workup done. And frankly, you got to be working with a doctor that has the experience, knows how to do the testing, knows how to find out if it's working, right? What test to order, how to interpret them, what kind of treatment plan do you do, how do you know if it's working? So I hope you found this helpful or even hopeful, and I'll see you next time.